let's now discover which are the new therapeutic algorithms, the novel drugs, and what are the gaps in implementation.
"20 years ago, we had first guidelines. Over the last 20 years, we made a fundamental improvement. Evidence is very solid. We are talking evidence-based medicine, which always underlies the guidelines.
It was important to make the algorithm for treatment simple. And I think we managed to draw a simple algorithm that is easy to follow, easy to be understood, and with the initial steps that should be taken. So we have an initial step where we can combine and put together ACE inhibitors and beta blockers. Then a second step with mineralocorticoid receptor antagonists. Then if patients are symptomatic, then we give the option to use the new drug LCZ696 or ivabradine. Of interest, the two drugs can be combined together. They can be used together in order to optimize the patient. Now, this is for pharmacology, but then at the same time, CRT can be used to improve function capacity and mortality and morbidity in these patients. Another important news is the suggestion to titrate diuretic throughout the patient journey. So we don't put diuretic at any specific place into the algorithm. They are put laterally, so it means with the recommendation of adjusting the diuretic dose according to the patient needs. We suggest that the ACE inhibitors can be combined to be the beta blockers from the beginning. What is important is that the beta blockers cannot be started before the ACE inhibition has been started. So try to up-titrate therapy, but up-titrate the ACE inhibition first for the full dose. While for beta blockers, we can be more lenient because on the dose, because we know that what is important is not target the beta blocker dose, but it's more the degree of heart rate reduction that is achieved that is important. So go high with ACE inhibition first, and in the same time build up your beta blockers.
We just need to follow this very solid evidence in the context of diagnosis and life-saving therapies, including pharmacology and devices. Then it would be it, plus multidisciplinary, comprehensive approach for virtually everybody.
The rationale for the study was that 2 years ago in the Lancet it was published that beta blockers do not work in heart failure with reduced ejection fraction and atrial fibrillation. That's why we've done our observational study, and we did our observational study in 11,000 patients, and we then did a propensity match study with 4,000 patients in each arm, and there we observed that if you add a beta blocker to an angiotensin converting enzyme inhibitor, we reduced mortality risk with 30% if the patient were followed for 5 years. If we want to learn more about beta blockers and atrial fibrillation and heart failure reduced ejection fraction, we have to conduct a new prospective randomized clinical trial, because if we do post-hoc analysis and small mechanistic studies, I think we will not learn enough. So if we really want to understand this issue, an important issue since 35% of our patients have AFib, so I think we have to do a new trial.
We started in 2010 collecting data in a pilot survey, collecting data in patients with heart failure, and we collected data for 5,000 patients. Then we started the Long-Term Registry. Up to now, 33 countries are working, collecting data, and we collected data on more than 25,000 patients. And our aim is mainly to see if the prescriptions to the patient are in agreement with the guidelines, which is the gap, if there is a gap, between guideline recommendation and clinical practice. And we published a couple of papers regarding this issue, one showing that the European cardiologists are I have to say, quite good in prescribing the recommended drugs, but in terms of dosages of these drugs, the situation is not so good, in the sense that they prescribe ACE inhibitor, beta blocker, or MRAs, but the dosages used are a little bit far from the targeted dosages recommended by the guidelines. And the same is true for the devices. The job of the registry from now on, it was already in the past, but from now on will be focused more on the alignment with registries, guidelines and educational program. Registry will collect information regarding the real practice, guidelines recommend what to do, and the educational program will be useful to narrow the gap between guidelines and clinical practice.
In heart failure with reduced ejection fraction, the one trial result we're awaiting is Commander HF. That's looking at a non-vitamin K oral anticoagulant. There are a couple of trials getting underway. One is Victoria with a soluble guanylate cyclase activator, a very SIGUAT, and another, and in fact there may be several, are trials with SGLT2/1 inhibitors. These are drugs for the treatment of diabetes. They block renal glucose reabsorption. They act as mild diuretics to lower blood pressure, so those might be of interest in patients with heart failure as well. And then I hope there will also be a trial with a novel inotropic agent, omecamtiv mecarbil, a drug that actually slightly prolongs the duration of systole and in that way enhances cardiac function. Again, that would be great to see studied in patients with reduced ejection fraction. In HFpEF, there's only really one big trial underway. That's Paragon heart failure. That's a study with sacubitril/valsartan, a drug that's recently been approved in HFrEF, a drug that blocks the renin-angiotensin system but also augments or increases natriuretic peptides. That treatment was effective in HFrEF. We hope it might also be effective in HFpEF.
There are several clinical trials showing that there is a little bit increase in the heart function, in the heart functionality after stem cell transplantation, but maybe stem cell power is just hidden by the comorbidity in the patients, including the aging. So we have to find out a way to take off all of these interference, all of this comorbidity that can affect the regenerative potentiality of the stem cells, and then empower them to do better in the patients. There are two possible ways. One way to directly go to the patients without cells, just by their culture medium. Another way is to make better cells in vitro first and then transplant them to the patients.
I just presented the results on my study on fibroblast growth factor 23. It's a novel biomarker that is produced by the osteoblast, and we think it might be of interest in heart failure because it's associated with RAS activation, signs and symptoms of sodium and volume overload, but also it has been shown that it can lead to left ventricular hypertrophy. Well, we used the biostat cohort for this analysis, and the biostat is a European cohort which was collected over the past couple of years, and it enrolled 2,516 patients with worsening heart failure or new onset heart failure. And these patients were also selected based on because they had to be on suboptimal treatment with ACE inhibitors, ARBs or beta blockers upon enrollment. And we assessed FGF23 in 2,399 patients within this cohort at baseline. And we found that patients with higher FGF3 levels had more severe heart failure, higher levels of RAS in the plasma, but we also found a tremendous association with outcome where patients in the highest level of FGF23 had a very high risk of experiencing the combined endpoint of all-cause mortality and heart failure hospitalization. So in summary, we feel based on these findings that FGF23 might be a very promising biomarker, but future studies will have to show whether it could also be modifiable.
The major problem is that a specific treatment until today for myocarditis is not established. The first thing what we have to do is that we really follow the guidelines how to treat heart failure. So these patients need a standard global medical treatment option which includes ACE inhibitors, beta blockers. When the ejection fraction is very low, lower than 35, also we need aldosterone antagonisms. And heart rate is high, ivabradine is also here recommended, and one of the specialties here is probably that we want to prevent sports and physical activity, because in myocarditis we have an inflammation, and we believe that, like if you have inflammation in other organs, for instance in the knee, that quietness is on a very important additional treatment options. New and probably also a very tricky point here to discuss is the role of rhythm diseases of sudden death. That is still not clear. Usually, of course, we will implant defibrillators in such kind of patients when they have for a long time and reduced ejection fraction. But since these patients also have a fair chance to response over the time with a nice recovery, it is not easy to decide how we shall bridge this time period, and the ESC guidelines here recommend to wear wearable vests to bridge these patients and to have here a recovery and safe period. Biopsies, MRI techniques are not specific enough to say and to bring us to the clue what kind of specific treatment options could be here reliable. So we need biopsies to exclude viral persistence. Everybody would understand that when we have a myocarditis and think about an anti-inflammatory treatment options, that we should not use immunosuppressive drugs when we still have a viral persistence. So only in patients where viral persistence had been excluded, we probably still would go for an immunosuppressive therapy with cortisone and azathioprine, at least when the acute phase of the disease is over. So no recovery time had helped for the probably next following 3-4 months after onset of the disease.